Yeah, such a nice location, and I'm a little bit envious because, of course, obviously, Kevin told you our lab's a little bit older already, 5 years. Some tear and wear already. So let's start from the beginning, of course. Since it's still very early in the morning, I won't bother you with too much scientific stuff. Instead, I want to give you a little insight in what we do with inertial measurement technology and how we use it in the clinical context in Duisburg. At first, let me introduce what the BG clinic and what the Athletikum is, in what setting we operate our motion lab there. I don't really have conflicts of interest. Kevin told you already, been customer since 2015, so that might be an issue there. Who we are and what we do is just some impressions of our lab. We've got this a motion lab, and right next to it there's a rehabilitation going on in athletes. We are rehabilitating after ligamentous injuries or after any sports trauma injuries that come into our clinic. And basically it's the Athletikum is structured into 4 big parts of work we care about. It's occupational injuries, because the BG clinics, most of you might know, but some maybe not, are part of an employees insurance association. They are funded by these associations, and our special focus is on sports trauma and on athletes, because professional athletes in Germany, they are insured by these associations, and so they come to our hospital and we analyze them, we have rehabilitation with them, and so we have got many cooperations with clubs from the region, but also with clubs all over Germany going on, who send us athletes after injury. And we're doing a lot of science there, mostly about ligamentous injuries, but also muscle injuries are being a major part of our work there. The idea was to set up a lab in 2015 to have a look at basic movements, like classic stuff like isokinetic, which isn't our topic today, but also complex movement tasks. So we would be able to have a better look, a multi-parametric look, a setup with EMG, with kinetics, with kinematics, to assess both sides, to get a picture of both sides, the athletic performance side on the one hand and the clinical function side on the other hand, and to integrate both sides to get a better look into why people get injured, why athletes get injured, and how to gather information to make them come back better or faster or at all. So why we need these inertial measurement units in our clinical settings. And I prepared a little video there, it's just 30 seconds. I cut it down. Oh no, this is another one, sorry. Have a look at this guy. He's coming down from a landing. Don't worry, it's come again in more slower. And he's disturbed in this landing process, and he's rupturing his ACL. So this is one point I would like to talk about in the next couple of minutes. Another one, another classic. This is not a disturbed landing, obviously. This is change of direction, and she's alone, she's not being tackled, but she's just changing direction, ruptures her ACL there. And this is the reason why the Employers Insurance Association formed this expert consensus process in 2015 and prepared this criteria-based approach to rehabilitation and functional movement analysis, the Return to Competition Manual. And we were part of this process, and since then we are testing athletes after these kinds of injuries. And what we wanted to see is, everybody I'm pretty sure knows this paper by which dealt with the knee abduction, and everybody was keen to measure knee abduction angles and measure dynamic valgus at that time point back in 2015. And still it's a major issue. It's being discussed, but it's still obviously a major issue. And we asked ourselves, okay, how can we do that? Because these kind of injuries, these non-contact injuries, and this dynamic valgus situation the athletes come into when they're disturbed or when they're changing directions, how can we measure that? How can we objectify our performance there? And therefore we met with a couple of colleagues in Ludwigshafen in the lab Ursula Trinler has set up there, and we tested our setup, our inertial measurement setup, with a marker-based setup, because we wanted to know, okay, which is the best way? Do we need this marker-based stuff, or do we go the way inertial measurement units gives a way to measure? And I think this video, it's just 30 seconds, but it shows the whole process of setting up a marker-based analysis, and it took us about 20 or 30 minutes, and in a clinical setting this is just isn't possible. It's not practical. So we said, okay, it's nice, it gives us valid information, but it's not the way we want to go, and therefore we are measuring with inertial sensors, and that's the way we do it in Duisburg. It's too time consuming to sum that up, and it's got a couple of other features, the IMU technology, which we really like. It's got a good model visualization. I'll come back to that later when it comes to giving biofeedback and rehabilitation and working with biofeedback with your athletes. And it's much more practical in terms of real life situations. You can take it outside, you can take it everywhere you want. You're not restricted to your lab situation. So that was a major point for us as well. And did anything change since 2015 when looking at injury situations and how athletes and how sports, how athletes injure? And a good colleague of mine, Christian Klein here, he's with the VBG. He did this really nice match injury analysis, video analysis of 300 something injuries in the first 3 leagues of German football, German soccer. And what they found out is that basically, when you're talking about non-contact ACL ruptures, it's still about disturbed landings, it's still about change of directions, and what they found out is there's a little bit more going on. The sport changes a bit. There are more tackling situations, more opponent tackles, which lead to injury. But the basis is still what we wanted to measure in 5 years ago. So that's what we do in Duisburg. Our return to sport process, it's just a little outtake, but the basis, the basics should be in there, is isokinetics. This is not our topic, but we're doing isokinetics, we're doing eccentric muscle testing, different speeds, eccentric, concentric protocols, and we're using it for training purposes as well. But this is always how we start off. We warm our athletes up and we're putting them on the isokinetic testing machine and having our data there. But that obviously doesn't have anything to do with IMUs. So let's go on here. And the next step is changing of direction. Doing a running analysis as well. Come back to that later. But one part of the test protocol is the 180-degree change of direction, because this is something very nice. We can, I'll show you, see the penultimate step here and the final step, change of direction and the push-off. We can see our force vectors here, how the leg accepts load and how the athlete changes direction. And the information the IMUs give us here are very, very important for us, because we can, on the one hand, see how much force they product, how much load the leg takes, but this is hip flexion. Might be a little bit small for you guys back there, but I hope it's going to work. You got another screen there? Oh, it's off, okay. Yeah, well, this is hip flexion, this is knee flexion, and she was injured on her right side. And we can see that there is not much change between the sides. Don't look too much at the absolute angles. We don't do that in our clinical context as well, because there's no good comparability to published data sometimes if you work with IMUs compared to marker-based systems. But what we do is having in mind that, for example, soccer players have got a very strong sidedness. That's for one part very important, but we have we still can compare body sides left to right and see the difference. She was injured on her right side, so there's not much compensation going on there, but what we can still see is this is rotational angles, hip and knee, that the blue, the right side, is more inward rotated through the whole contact phase of the change of direction on her right side. And yeah, well, actually for the hip, that's the same. This is just one part of the analysis, so we're putting pieces together. It's not like, okay, your hip is more inward rotated and your knee is more inward rotated. In this specific test, you can't go back to sports. You're not ready. Because there might be a completely different picture in another test, so there has to be a consistent phenomenon. We are looking for consistent phenomena all over the return to sports test battery. It's not just one test that's important to us, it's more like the whole picture we are trying to get. Next thing is not so standardized, like the cutting on the force plates with a clear, okay, go 10 times, change of direction, 180 degrees. This is more like a real life situation, because there's an opponent here who is disturbing her, and we're trying to imitate a real life situation. She's doing her cut, like 45 degrees cutting or 60 degrees cut, and we're looking at IMU angles to see whether she's doing it differently, left side to right side. And what you can see is, because this is a more complex task, she's got more degrees of freedom, more ways to solve this task, and the variability of the data is much, much bigger. So you have to be more careful how to interpret this data. But still, she was injured on her left side. You can see the knee abduction here, left is red, is much higher on her left side. Knee rotation, well, I wouldn't make too much of that. Too much variability, and for me that's not a criteria. Maybe you could see that she's rotating faster. There's a steeper angle of this curve here on the left side, but well, just keep that in the back of your head. Of course, we're doing hop tests, the classic hop test. We're doing the counter movement jump, the drop jumps, single leg drop jumps, which is sort of quite a task for most of the athletes, the single leg jumps and the hop for distance. And we're looking at force development over the force plates, and we're looking for secondary knee angles, knee abduction, rotation of the hip, abduction of the hip. She's doing quite a good job there from the video analysis, but still you can see that she's unloading her right leg. This is the gal that was injured on her right side here, blue. Less knee flexion and less hip flexion. This is rotation, hip rotation at the top, knee rotation under the hip, and there you can see that she's solving this task quite differently, left side to right side. There's more inward rotated knee on her right side. So this was another point to check on our list. Okay, change of directions, drop jumps, there might be still an issue with leg axis stability with her. Basically, that's what we do in return to sports. It's change of directions, it's hopping, and it's sprinting as well. Didn't show you that. But of course, it's not all about athletes. In our clinic, there are a couple of other patients coming to us with sports-related injuries, but they are just recreational runners like you and me, or recreational team sports. And I want to show you some examples of those people as well. First one I brought is actually a colleague who's working in one of our in our clinic. She's 44 years, recreational runner, quite ambitious, 80 kilometers per week. And after a period of I would call it overtraining, she was training on ice in early 2020, and she did that for 3 weeks and developed this medial tibial stress syndrome there, which was very prominent on the MRI. And what she did was nothing. She had no structured physiotherapy or training therapy at all. She was told just to take some painkillers and take 6 weeks off training, and then start slowly to take up her training slowly again, which obviously wasn't a good idea, because from the first step she was having pain again. And then we did this running analysis with her. What you can see here, she's having the stress syndrome on her left side. Look at her feet. We've got the pressure here as well. Look at the lateral aspect of her foot on the left side. What you can see is that she's still deloading and moving quite differently. And when you look into literature, you can see that 3 things are very, very common with medial stress syndrome, and that is the early push-off, it's called apropulsive push-off, and then very fast and elevated inversion compared to the contralateral side, as well as this little abductory twist. And we were able to show that with our inertial measurement here quite clearly. The left side is injured here in red, and she's taking her heel off earlier than on the other side. She's much more inverted on her left side, and when she's pushing off, she's getting this little twist on her ankle, so she's getting a lot of stress on her tibialis posterior and on the deeper foot muscles. And now we're trying to address that, making her stronger with the deep calf muscles and foot muscles, and let's see how that works for her. And of course, this is going to be an issue with the uptake of her running training, because that should be very, very step by step and not 80 kilometers to start off with. Second one I brought for you is a hockey trainer with a very, very good hockey club in Duisburg, and he's training his athletes there, but still playing quite a lot himself. And he's had an ACL reconstruction 5 years ago, some meniscal tears which were resected back then, and everything went well. He had his rehabilitation, and he's running 3 times a week, and he's playing and training hockey, field hockey. But he developed this pain on his, he had this ACL on the left side, I think, and now he was coming with pain on the right hip and on the right lower back. And he was telling me, Arthur, I don't know, but I don't think I'm really running, I'm doing a good job running there. Can you have a look at that? And there was nothing on the MRI, and no training therapy so far, no physiotherapy. And we had this running analysis. And what he thought he was doing was, yeah, well, have a look at it. It's quite clear. Because his feeling of not running round, it was very, very objectified by the IMU measurement. Look at the right knee here. It's almost stiff as well as the hip compared to the contralateral side. And he was deloading massively on the left side, and getting much more load on the right side, which looked like this. This is force, deloading on the left side, much more loading on the right side, and this is what it looked like for the inertial measurement units. He's simply not using his left leg and compensating so much in his right hip that he developed this pain because of all the tension going on the abductors, on the deeper gluteal muscles, and on the lower back. So this is maybe an easy thing to fix, because we have to push the reset button on his past ACL rehab, because this wasn't finished, obviously, because I think this is the way he was running for 5 years, and because he was in quite a good shape for his age, he was able to compensate it up to this point. But now we have to push the reset button on that rehab and start a little bit all over again. But it's a good way to be able to show this to people, because for him it was just a feeling, okay, I don't feel well when I'm running not round, and this was a good way just to show him, have a look at this. This is a complete catastrophe. Third patient I brought is a keeper, a woman keeper, which actually was an intern in the Athletikum for quite some time. And first division in Duisburg, she had an ACL in 2017, another one in 2019, both non-contact ACL injuries, and another arthroscopy in 2019 to get rid of some scar tissue. And yeah, she was still laboring around with painful tibial bone bruises and stuff like that. And we did a lot of testing with her throughout all of her rehab. We did changes of direction, and what you can see here is after that time that she's still, you can see that on the screen, she's still deloading her left knee, was injured on her left side, and compensating with more hip flexion for the stiffer knee. But actually we thought the surgeons and the rehab team did quite a good job with her axis stability, because she wasn't showing too much abduction or too much rotation. So sorry, this one just slipped in, but I might as well show you, because this is quite an interesting case. It was a hurdle sprinter, 19 years with a hip dysplasia, and it was and he developed this labrum tear because of the hip dysplasia, couldn't run anymore, and it was fixed 4 months post-operatively. You can see there's still a massive lack of hip flexion and a massively higher hip adduction on his surgically treated site. And after, I didn't bring that. Sorry, I can show you. Because it's a nice example of how we can see what's happening over time in rehabilitation. And this is a picture 2 months later after rehabilitation. His hip flexion quite nicely recovered, as well as his hip adduction. They are getting closer to each other, and he's still sprinting and still happy with the outcome of his surgery. So we also use these inertial measurement units just to show ourselves and the patients, and of course the surgeons, how patients develop over time. So what else can we do with these IMUs? We can use them not just to do diagnostic, but to train people, to coach people. And this is one way we are using it when people come with running related problems. We're giving them maybe just one sensor, put them on the hip, and giving them the hip movement to have a look at the hip movement on the screen in front of them. And we don't say much. It's not like fix your hip, or just get a more balanced picture here. Try to balance your hip more, that it's not like tilting on this side, that it's more balanced. And the rest is up to the patient. He has to find a way to do that himself, which is a good way in biofeedback to give them the opportunity to solve this problem for themselves. You can also use the other data that's coming from the IMUs, like acceleration. There's we asked this patient to do this stability test. Actually, you can do it without the testing tool. It's just about doing a single leg stance and having a stable knee there. And we were giving them the acceleration signals and putting a cutoff here, which issues a sound when it's going when he's too unstable, it's just making bing, 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 and so the patient can control himself and control his stability to get better in this kind of movements.